There we go. I forgot to record last class, so I need to make sure I get this one. All right, so no significant medical history, no drug allergies. We've acknowledged that she has failed her 1 hour glucose, but she passed her 3 hour. Here is her labs on admission. A hemoglobin of 12.2, a hematocrit of 36.6, white blood cell count of 12,000, and platelets were 218. So based on this, everything looks normal, right? Would you guys agree? All of this looks fine on admission. So let's see what happens with her delivery. So this is a little delivery note from our provider. Blood loss was 300 mLs after delivery. The placenta was inspected at the time of delivery and appeared to be intact based on the delivery note. There was only a first-degree laceration that did not require repair. Our baby weighed 4120 grams, and the patient has an IV line in place with oxytocin infusing. What stands out to you in this page here?
The baby's a little on the heavier side.
Yeah, we got a big baby. 4120 grams at 39 weeks is a pretty big baby. What else? What about her blood loss? What is that? Is that normal?
It's within normal, isn't it? Under 500?
Under 500 for vaginal delivery. The
Under a
normal.
thousand for
Mm-hmm.
C-section?
Yep, you got it. Under 1,000 for C-section. So her blood loss right now, based on her delivery, is fine. Okay. So we have a big baby, we have normal blood loss. So let's move on here. Based on the information provided, what might Marla be at a risk for? Based on all of the information you know about this patient, what is she at a high risk for?
Post-op hemorrhage.
Yeah, a postpartum hemorrhage. And what information in our case study um, can indicate that to you, or can you, or tells you that that patient might be at a risk for this?
The unrepaired laceration.
Yes, what else?
The fact that she had a large baby.
Yes, she had a big baby. She had an unrepaired laceration. What else about her history can we, and maybe doesn't necessarily mean she is going to hemorrhage, but can be kind of something that we need to keep in mind.
Her
She had
age?
Oh, sorry. What was that?
Spontaneous delivery.
Yeah, she had a spontaneous vaginal delivery is normal. That doesn't necessarily mean she'll hemorrhage. But Hope, what did you say?
With her age, and maybe she's on medications that might cause bleeding.
Sometimes advanced maternal age can be a risk factor for postpartum hemorrhage, but what I'm looking for mostly here is the fact that this is her sixth pregnancy, right? So anytime we have a uterus that has been stretched and has grown multiple times, that can potentially lead to subinvolution following deliveries. So we need to just keep that in mind that she is more at risk for hypotonia in her uterus than a primate, right? Or a first-time mom because her body has gone through this multiple times. All right. So we know this. We've seen that she's got that big baby. She has advanced maternal age. She's been pregnant multiple times. And now her call light goes off. The nurse enters the room. Marla emphasizes that this is much more bleeding than her other deliveries. She says she's feeling faint and dizzy. What should the nurse do first?
massaged the fundus.
Yes, we want to massage our fundus. Exactly. If a patient is ever bleeding, we want to prioritize stopping the bleed. The best way and the most effective way to stop a bleed of a postpartum hemorrhage is by massaging that fundus. So we want to go in and massage the fundus. What other information are we going to want to know about this patient?
Her blood type.
Yeah, her blood type. What else?
Her vitals.
Blood is lost.
Vitals, how much more blood she has lost. Excellent. Yeah. So we get her vitals. Her blood pressure is 130 over 80. Heart rate is 105. Her EBL is now up to 500, so she's had an additional 200 out. No evidence of additional lacerations, no evidence of retained placental fragments, but the uterus continues to be boggy. What other things should we be considering at this time?
Is her bladder full?
Yes, we can assess for a full bladder, feel for any bladder distension, see where that fundus is. Someone quick before we continue in this question, what is a normal fundal exam? Like, what do we want to see when we're assessing a fundus?
That is firm.
Firm, yep.
That it's like centered.
Yep, it's midline. Firm, midline. Where do we want our fundus to be? Really, really quickly soon after delivery. Usually, where does it fall?
The umbilicus?
Yeah, at the umbilicus. Yeah, for sure. So for a good fundal exam, we want it to be midline, firm, and at the umbilicus, okay, with minimal amounts of bleeding. So we talked about looking at her bladder because if we have a full bladder, we can sometimes have uterine distension, right, where it goes off to one side or the other of the abdomen. So we'll look at her bladder. What other things should we consider for this patient? Do we want to call our doctor? Yeah, we need to call our doctor. If your patient is bleeding, especially if we've already had another additional 200 out and now we're at that 500 limit for vaginal delivery, we for sure want to give our provider a call. Okay. So somebody give me an S bar. Someone pretend like you're calling me with report on this patient.
"38-year-old female, status post-spontaneous vaginal delivery of a term uh, newborn. Um, Currently at 500 milliliters of blood loss. Uterus is, or fundus is boggy. I don't know what else."
No, that's perfect. That is perfect. You should be a labor and delivery nurse, Kristen. That was great. Yeah, so whenever you're calling a report on a patient and it's a little bit emergent, we do not need to tell the provider she has no known allergies or she has no underlying medical history. We need to tell them the important stuff. So you're saying, hi, this is so and so. I'm taking care of your patient Marla. She is 30 minutes post spontaneous vaginal delivery. EBL at delivery was 300. She has now had an additional 200 mLs out for me at the bedside in the recovery period. You tell them their vital signs. You tell them how they're assessing. If you're getting clots out, you're telling them how big the clots are. You're telling them what the fundus feels like and where it is at and where it's located. Then you're asking for orders. So all of this is happening. This is what my patient is doing. And now I would like blank. So it's either I need you to come into the hospital for further evaluation, or I need orders for more uterotonic medications to stop this bleed. Okay. if you are on the phone with a provider and you're telling them that she's got like two boys and two girls at home, they're gonna just be like, okay, cool. Like I don't care. Like tell me the important stuff. So you want it to be short, sweet, and full of the information that they really want to know. So we've called purport for our provider. We go into the beds. We're hopefully calling them from the bedside because you shouldn't stop massaging a fundus if it's boggy. But we do another blood pressure and everything in 2 minutes. Blood pressure is 110 over 70. Heart rate is 120. Now she's up to a total of 750 mLs out. Her uterus remains boggy. Marla states she's feeling worse and is very much worried. Her husband asks, why is she bleeding so much? She looks like she is kind of pale. What other considerations should we take into consideration for this patient at this time? So first off, what are the medications that we could give her to stop her bleeding?
Hemabate,
Hemabate, and who do we not give that to?
asthmatics.
Yes, people with asthma. All right, awesome. What's another one?
Methergin,
Methergin, and who do we not give that medication to?
high blood
High
pressure.
blood pressure.
High blood pressure. So could Marla get that medication? Could she get both Hemabate and Methergin, really? Yeah, she doesn't have any underlying medical history, and her blood pressures have been low, not high. So she is a candidate for both those medications. What is the last med that we will give?
She's still on the oxytocin infusion, isn't she?
Yes, she is. So she's getting oxytocin. We covered our Methergin and our Hemabate. There's a fourth medication that we can give in the case of a postpartum hemorrhage or excessive bleed. It is Cytotec. Cytotec is that fourth medication that we can give to a patient postpartum if they're bleeding too much. So at this point, your provider, you've called your provider, they gave you orders for these medications. So at this point, we're going to be administering those meds. Okay. What else should we consider? We've thought about emptying her bladder. We're giving her these medications to stop her bleeding. What else should we probably be doing at this time?
Do we have orders for blood transfusion?
That is a great next step. We probably should be thinking about volume expanders. We probably already should be administering a fluid bolus, even if it is just LR, normal saline, whatever you have you. We need to give this patient some fluids to try and increase her blood pressure. Okay. At this point, too, it would not be a bad idea to put your patient on low flow oxygen just to maintain O2 saturation and continue perfusion. Okay. You are still going to be massaging this fundus if it's boggy. That's something that you'll be doing throughout this entire process. So this has now become probably a 3 nurse job in this room. Okay. All right, her blood pressure is now 90 over 65. Her heart rate is 125. She has now a total of 1,000 mLs of blood lost. Her uterus remains boggy. Marla says she thinks she will pass out. Her husband asks, is she going to die? What other considerations should we consider for this patient?
Having an OR available.
Potentially having an OR available. Yep. what position should this patient be in if she's feeling like she's going to be faint and she's had this much blood out and her vitals look this way?
Trendelenburg.
Trendelenburg or laying down with her feet elevated. Yep. We definitely need to have our provider at the bedside. And you can see how quickly this progresses. This has only been a total of like 8 to 10 minutes since you've been at the bedside in this room, right? So her blood pressure is really low, her heart rate is elevated, her blood loss is that indicates that she's had a lot more blood loss. So if we haven't typed in cross match for units of blood or ordered stat blood, we probably should be doing that now. What are some other things that we can do besides medications for a postpartum hemorrhage without going straight back to the OR? What would a provider, like, what could a provider do if they come into the bedside?
Would they do like an exam to see where it's coming from?
Yes, what kind of exam?
I guess a vaginal exam.
So they would do a vaginal exam. They would do what's called manual extraction, where they would put their hand up into the vagina and do a manual sweep of the uterus to ensure that all the retained products have come out. Obviously, this is not enjoyable for the patient. That is extremely uncomfortable, especially if they do not have an epidural or anything during labor, and this is something they're experiencing unmedicated. So, as the bedside nurse, we need to be there to support with the patient, potentially medicate if possible. But her blood pressure is already super low and she's symptomatic. So, administering pain medication to this patient at this time may not be the best idea. So, if a provider does a manual sweep, what should we anticipate the provider ordering following a manual sweep? What is this patient at risk for if they just had a doctor stick their whole hand up into their uterus?
Infection.
Infection. So antibiotics.
So we need antibiotics, yeah. So if we do a manual extraction following the postpartum hemorrhage, this provider is going to order antibiotics to be administered. Okay, so we can do medications. We've done our interventions. We've repositioned her. We're administering fluids. We're giving her oxygen. We're getting a blood type and screened, cross cross matched. The providers at the bedside, they're going to do a manual extraction to try and figure out where this bleeding is coming from and make sure there's nothing retained up in the uterus. We also could maybe do an ultrasound. Ultrasounds, though, if there's this much bleeding, are not always effective because they can be hard to visualize if there's a lot of blood in the peritoneum or filling up the uterus. Okay, so ultrasound is not always effective in this situation. Let's see what happens. Now her blood pressure is 80/60. Her heart rate is 140. Her EBO is 1500. Uterus is feeling firm and her flow is decreasing. So her flow is decreasing. She is still bleeding a little bit. She just had some more blood loss. What other things could we possibly do for this patient? Think about like a manual device or something to help with the uterus. Do you guys remember like when we talked about Bakri balloons? So a Bakri balloon is a device that is going to be inserted by a provider up into the uterus that expands and manually contracts the uterus for us. A device that we now use that's a lot more common practice is a JADA, which is hooked up to the wall section in the um, delivery room. So either of these devices could be an option to us if our medications are not successful and if this patient is still bleeding and her fundus is not firm. So those are some things that we can use as well if we need to. If we have a Bakri balloon in and we have, or a JADA device, and we've given all the medications we can give, we've done a manual extraction, this patient is still bleeding profusely, then we are going back to the OR and they're going to try and do an examination while the patient is sedated. And if they cannot find the source of the bleed, sometimes that can lead to an emergency hysterectomy, which is absolute worst case scenario. But hemorrhages can progress to that point sometimes, unfortunately. All right. So now our patient, her blood pressure is 110/75, her heart rate is 105, her total EBL now is 1600, her fundus is firm at the umbilicus, and lochia is scant. Marla states she's feeling much better. What other considerations should we take into consideration for this patient at this time?
If she lost a lot of blood, maybe she might be deficient in iron now. So maybe just um, making sure that she's taking in some through her diet.
Yeah, monitor her labs for sure. This patient is a candidate that we're going to need repeat H&Hs on because we're going to need to see what her hemoglobin and her hematocrit drop to. We're most likely giving this patient already a unit, if not 2 units of blood, but we need to be able to monitor it because she may need more than that, depending on what her levels are, right? What else for this patient? You're in the recovery phase, so are you going to leave this patient's bedside still? No, this patient is going to need to recover almost like you're basically starting over with this recovery period. Okay. Um, and then obviously, if she's feeling much better, then we can start doing skin to skin with her baby. Then we can start looking into breastfeeding and doing all the things that we normally do postpartum, right? So then now she becomes a recovery of a delivery. So this isn't part of this PowerPoint presentation, but let's go back and think about our infant. Okay, we had a baby that was 4120 grams. Mom failed the first blood sugar, the 1 hour glucose. So what might we anticipate needing to do for this newborn?
Monitoring their blood sugar.
Monitor the blood sugar. Yeah. So your mom is currently having a postpartum hemorrhage. Is now the appropriate time to initiate breastfeeding? No, that is not a priority, okay? If you try to latch a baby onto a mom who's having out all this bleeding, that would be absolutely crazy. So unfortunately, these kind of things happen all the time where you have a bad mom and you also have a bad baby because usually what is happening with one is affecting the other, vice versa. So if you're the primary nurse and you're taking care of this mom, but you know that this baby is large for gestational age and is going to require blood sugars and also probably some supplementation, we need to get another nurse in to help us with this. Okay, especially if you're in an LDRP or a smaller facility where you're doing all of the care for a couplet. Okay, so you have both mom and the baby. So if we know mom is having a postpartum hemorrhage, she's gone back to the OR because her bleeding is so intense, and we know this baby's big, and we get a blood sugar of 30. What should we do?
Feed the baby.
Feed the baby. Unfortunately, we're going to have to probably feed that baby formula. And that's something we're going to have to either get consent from dad or support person or partner, whoever is there with mom and who can consent to us doing this for the baby. But if no one is around for consent, we're probably going to administer that oral glucose gel and then see what the blood sugar is after that. And we may need to give formula independently because it's medically indicated. All right. Um, if we know that baby is hypoglycemic, what else are they at risk for?
Like uh, hypothermia or like not able to control their temperature.
Yes, they're not going to be able to thermoregulate, so they are at increased risk for hypothermia. If they become really cold, hypothermic, what else could they potentially have happen?
Is it shock?
So they could just start declining rapidly, and it can lead to some respiratory depression, right? They're already in a metabolic state because of the hypoglycemia and then the hypothermia. As we talked about whenever we were going over our newborn slide, babies only have a specific amount of brown fat in their body for reserves to compensate for whenever they become cold. If they burn through this brown fat, they can't shiver. They're not going to shiver to warm up their body. Their body is going to compensate. They're going to enter into a more of a complex state of acidosis, and it can lead to respiratory distress. Okay. So all of these things are combined. All of these things are tied in together. Another thing with hypoglycemic infants is that we're worried about is hyperbilirubinemia, right? So these babies could become jaundiced. They're at a high risk for having some jaundice, especially a bigger baby like this one. Okay. Because we know with hyperbilirubinemia, the babies that are at risk are preterm newborns, also large for gestational age and small for gestational age infants. All right. Questions on that one, guys? Let's move on ahead. All right. So now we have Mrs. Lynn, who is a 36-year-old G3P2 patient at 39 weeks, who's being admitted for an induction of labor. She had a previous history of delivering two 9-pound babies within the last 6 years. She remembers that the deliveries were difficult and she had a tear in the cervix and bled a lot. Mrs. Lynn has a documented 50-pound weight gain during this pregnancy. She arrives today stating that she is glad she was scheduled to be induced today because she has had this headache for 3 days now, and Tylenol just won't touch it. I think this is what is making everything seem blurry. I'm ready to be done. What stands out to you about Mrs. Lynn?
History of large babies.
History of large babies.
She also has a headache with blurry vision.
Yes, a headache with blurry vision.
The
Wait,
tear in the cervix and the bled a lot in the past.
Yeah, she has a history of a postpartum hemorrhage with a cervical laceration. What else? I think somebody said something else.
her 50-pound weight gain.
A 50-pound weight gain. So I'm glad you pointed out the 50-pound weight gain. So when we read that this patient has a headache for 3 days now, and Tylenol won't touch it, and she has blurry vision, what are we thinking this patient is at risk for?
Preeclampsia.
Eclampsia.
Yeah. So what is something we also know about preeclampsia that could potentially be behind this large amount of weight gain?
Fluid.
Fluid. This patient is retaining fluid. So, yes, she may be just overweight during this pregnancy. She may have put on more weight than we recommend. But if we know that she's showing signs of preeclampsia, we need to check her lower legs and her body in general for edema because that could be contributing to the 50-pound weight gain, right? Okay, so we said the big babies, we said the weight gain, we said the headache and the tear and the bleeding. Um, I think that we covered all the big ones. So let's see what happens here. Her history. So she was also diagnosed with gestational diabetes at 26 weeks. which she was managing with diet and exercise and daily blood glucose monitoring. An ultrasound was done 2 weeks ago at 37 weeks because her fundal height was 39 centimeters. Her ultrasound results showed that the estimated fetal weight was 4,000 grams. So in this slide, we know that she has a history of gestational diabetes in a previous pregnancy. Well, her past medical history was that she has a history of gestational diabetes. She has a history of delivering macrosomic babies. She has gestational hypertension in a previous pregnancy, and she is overweight. So looking at this patient now, or looking at this slide, what are things that stand out to you about this current pregnancy up here?
Is it the fetal weight?
Yeah, this is already, we know this is a big baby for sure. And that's why we did the ultrasound because her fundal height was measuring 39 centimeters at 37 weeks. What else?
And she was diagnosed with diabetes at 26 weeks.
Yeah, she's a gestational diabetic. Yep. All right. So we kind of already talked about it, but based on the information that we just learned about her, what is she at risk for? Taking into consideration all the things.
Shoulder dystocia,
Yes,
possible.
because of her big baby, right? What else is she at risk for?
Postpartum hemorrhage.
She's at risk for a postpartum hemorrhage because of her big baby, right? What about like her admission stuff? Like we kind of talked about it already, but she has this blurry vision and this large amount of weight gain. What do we think could be happening with her?
Preeclampsia.
Preeclampsia. Yep. All right. Here is her admission labs and values. So her blood pressure is 152 over 92, heart rate of 90, respiratory rate of 21 breaths a minute, and her temperature is 98.2. Her labs, her glucose is 125, AST is 122, ALT is 98, PCR ratio is 0.62, platelets are 90,000, and fibrinogen are 402. As far as the baby goes, baby's heart rate is 140. She has moderate variability, accelerations, and does not have any D cells. Her cervical check was 3 centimeters dilated, 70% effaced, -2 stations, soft and anterior, with a Bishop score of 9. What do we think about all this?
She has HELP syndrome.
She has HELP syndrome. Yes, Joni, what makes you say that?
Her liver function, her platelets, um,
Her AS with those liver, is that what are those values? Are those high or low?
high.
Those are elevated. Yeah. Her AST and ALT are elevated.
Yeah,
Platelets, what about those?
too low.
Those are low. Yep.
And her fibrinogen would mean she's at risk for bleeding.
Potentially, yes. So the other one too that we need to look at is her PCR ratio. Is that normal? What does that tell us? When do we start to get concerned about a PCR? if it's over 0.3. So a PCR ratio, protein creatinine ratio, this means that this patient is spilling protein into her urine. All right. So this is another indicator of preeclampsia, eclampsia, HELLP syndrome, all of those things. Okay. What about our baby? How does our baby look?
Doesn't it look like she is a good candidate to have this baby now?
Well, the baby looks fine. Yeah. So we're not worried about the fetal heart rate at all. That fetal heart rate is normal. Moderate variability is what we want to see. We want to see accelerations and we do not want to see decels. So this is a normal fetal heart rate tracing. Okay, her cervix and her Bishop score of 9, that is more of an indicator that she is a candidate for an induction. So thinking and seeing all of these labs and how the patient presents, what are we anticipating that we need to do? What are we anticipating, like our orders? What do you guys think is going to happen here?
Gonna start her on mag.
We're going to start her on MAG because not only does she have elevated blood pressure, right? It's not in the severe range where it's 160 over 110, but she's symptomatic and she has lab values that are indicating that there's something else going on. So we're anticipating we're anticipating getting orders for magnesium. What else? So this patient literally just walked through the door. We have lab values. What else are we going to need for her? Start at the very beginning.
An IV.
We need an IV? Yes. We need probably two because if we know that we're going to be giving magnesium, we know that magnesium is not compatible with really anything else. So we're going to need 2 large bore IVs inserted for this patient. What else do we need?
Calcium gluconate at the bedside.
Calcium gluconate at the bedside. Our normal admission stuff. We need to get her HMP. We need to get an assessment done. We need to, right? We need to have an assessment because if we call our provider, that's one of the first things they're going to ask is what are her deep tendon reflexes? What does her edema look like? Are her lungs clear? Right? So we need an assessment. But yes, this patient is going to be on magnesium. If we need this baby to be delivered, what else are we going to probably administer along with the magnesium?
You mean like Pitocin?
Yeah, Pitocin. That is the induction method that we're going to need to use for this patient. Okay. All right. So we have 2 large bore IVs. We have her on the blood pressure cuff. She's on the monitor. We've got her assessment done. She gets, let me see, MAG. Okay. This first question up here is a math question if you guys want to write it down and practice, but I'm going to kind of just keep moving it along just because we have a lot to go through tonight. So mag sulfate is started via IV infusion with a 4-gram bolus and is now infusing at 2 grams an hour. The magnesium is supplied at 20 grams in 500 mLs. What's our infusion rate? If you guys want to practice that for your HESI, feel free. So why do we administer magnesium?
To make sure that they don't, it don't turn into eclampsia.
Yeah, so that they don't have a seizure. Yeah, this is a seizure prevention med. So what assessments do we need to do on our patient every hour if they are receiving magnesium? What focused assessment do we do for mag?
Is it neuro?
We want to see if our patient's alert and oriented. Yep. Neuro check.
And definitely urine output.
Yes, urine output. That is a big one.
And respiratory rate.
Respiratory rate. Yep. We're gonna do a full we're gonna listen to her lungs and count respirations. What else do we want to assess as well?
The fetal heart rate.
Yes, we're going to be continuously monitoring our fetal heart rate, but we also want to monitor mom's deep tendon reflexes. Make sure that they're still present. Okay. What are our signs and symptoms of magnesium toxicity?
Respiratory depression,
Yep, respiratory depression.
loss of deep tendon reflexes,
Yep, loss of absent deep tendon reflexes. Are they going to be alert and oriented times 4? Most likely not.
may have like heart dysrhythmias.
They potentially could. We're also worried about respiratory rate and also like hypotension can be one, right? They also aren't going to have any urine out. Their urine output is going to be very minimal, if not absent. Okay. So what is our treatment for mag toxicity?
Calcium gluconate.
Stop the
Or
infusion.
stop the infusion.
Calcium gluconate is the treatment. We are definitely going to stop the infusion though, if we suspect that this patient is showing signs and symptoms of magnesium toxicity. All right. So later in the day, we go and check our patient. She is 10 centimeters, 100% effaced, and the baby is at +2 station. The patient pushes with every contraction for over an hour with minimal progress. After an additional hour of pushing, the baby is 3+3 station. Physician applies forceps to assist with delivery and descent, and after 3 contractions, the head of the baby is delivered. The head advances slightly, then retracts back up, turtling, and the shoulders did not come out. What is the cause of this? What is happening?
Shoulder dystocia.
Yep, we have a shoulder dystocia. The provider calls for interventions for shoulder dystocia. The nurse should anticipate doing the following. What are we going to do for shoulder dystocia?
What's the maneuver? I can't remember.
You got it. It starts with an M.
Oh my gosh. I can't remember it. Oh, wait. I can't remember it.
Is it McRoberts?
McRoberts, yeah. McRoberts maneuver. What else do we do? Well, what is the McRoberts maneuver first? How do we do that? How would we do the McRoberts maneuver?
I'm trying to think. I think you like push down.
So
Hit
that
the thighs and press it to the admin.
so you're going to extend the patient's legs and then bring them shooting right back up to her chest. So you'll have a nurse on each side helping extend the legs. Okay. And bring them up to the patient's chest. Sorry, you guys are going to see my dog and he's in a cone right now. Say hello. He just looks really goofy. Okay, so we have the McRoberts maneuver. What else are we gonna do with the McRoberts? You kind of were getting at it with it, Joni, there for a second. What are we gonna apply?
Pressure.
Yeah, suprapubic pressure to try and release that shoulder from underneath mom's pubic bone. If McRoberts and suprapubic pressure do not work, they're not effective, what do we do? What's another thing that we can try?
The Gaskins maneuver,
Gaskins, yes. And what is that?
when the mother's on like all fours, I think.
Yes, it's hands and knees. Yep, you got it. So, in the case of a shoulder dystocia, what is our priority? What are we the most concerned with?
Injury to the fetus.
So, we're going to be worried about that afterwards, but what's our priority during a shoulder dystocia? Why are we doing all these maneuvers and everything? Why are we doing all these interventions?
You want to deliver the baby like within 5 minutes, I think, or else they don't get enough oxygen.
Yes, our priority is fetal oxygenation and delivery of the fetus. That is our priority for this patient. So, yes, that's exactly right, Haley. We need that baby to deliver. If that baby is not out within a certain time frame, we may have to do surgical intervention. I've never been a part of a shoulder dystocia that has needed surgical intervention, thankfully, but that would be what we would do next if we physically cannot get this baby out. Okay. All right. The physician requests for McRoberts maneuver followed by suprapubic pressure. The baby's delivered with an APGAR score of 7 at 1 minute and 8 at 5 minutes and a birth weight of 4,200 grams. So, are these APGAR scores normal?
No.
They're not? You don't think?
I mean, yeah, but I mean, I guess I would worry about if the baby was like, never mind. I was going to say that the baby might be at risk for like meconium aspiration or like a respiratory issue.
Yeah, so based on our APGARs now, those APGARs are okay. Anything over 7 we're fine with, right? But your train of thought with the meconium aspiration and any other type of respiratory symptom is not completely, it's not wrong because if a baby is having distress as far as like a shoulder dystocia or something like that, most likely they did probably pass a bowel movement in utero. We just didn't put that um, as part of this case study. But yes, if a baby has distress and has some meconium, we're worried about respiratory distress and meconium aspiration. Um, Knowing the APGARs that we have and then the baby's weight and that we did McRoberts and we had a shoulder dystocia, what else is our baby at risk for?
Like a brachial plexus injury,
Brachial plexus injury, yeah.
or maybe like a cephalohematoma or something.
Cephalohematoma, yeah, we did have to use some forceps, so there could be some damage. Um,
And
what's
then his
another injury that's very common with a shoulder dystocia?
like a fractured clavicle.
Yes, a clavicle fracture. Yep. Awesome. So we can be worried about some brain, some head trauma, some swelling. following a rough delivery like this one. We're also very worried about any clavicle fractures or a brachial plexus injury because of the shoulder dystocia. Um, and then we can also just monitor this baby for any other types of bruising. So if we have injury or baby has excessive bruising or there is like a fracture or something, what will that automatically put the baby at risk for?
Well, if it's the head, like a hematoma, then jaundice.
Yeah, we're worried about hyperbilirubinemia for sure. So that's awesome. Yes, we're definitely worried about all of that. Um, with our big baby and the size of this baby, what are we worried about?
Hypoglycemia.
Hypoglycemia, which can lead to a whole bunch of other different kinds of issues. Okay. How are we going to assess this newborn for any of these issues or these problems? Let's start with like an injury from the shoulder dystocia. How are we going to monitor or assess for that?
The Moro reflex.
Yeah, we'll check our reflexes. So we'll do the Moro reflex. Um, we'll check for that one. We also can palpate the clavicle, and if it's broken or fractured, we can feel that crepitus underneath whenever we're assessing that spot. And then obviously for hypoglycemia, we're going to be getting blood sugars, and to assess for hyperbilirubinemia, we're going to be drawing the baby's blood at 24 hours old. Okay. So how long after delivery do we think Mrs. Lynn is going to keep getting magnesium?
Isn't it 24 hours?
Yeah, it's typically 24 hours is we're going to be giving these patients magnesium. What would be some signs that her preeclampsia is resolving?
Blood pressure, edema.
Yep. Yep, all of those are going to start to resolve. What else?
Her headache subsides.
Her headache could subside. Yep. She's going to just have a reduced amount of those side effects that she was having earlier. What risk is increased in the postpartum period for patients on MAG?
You mean like mag toxicity?
No, so I mean, like, if you have a patient who's been receiving magnesium for prolonged amounts of time, what are they at an increased risk for? Think about what magnesium does in the body, right? It's a depressant. It causes everything to relax. So if you know a patient's been on magnesium for a long amount of time, everything is relaxing. What are they
Oh,
at?
then like the the uterus won't contract, like you would be worried.
Yeah, so you're worried about what if the uterus isn't going to contract?
Postpartum hemorrhage.
Yeah, we're worried about a postpartum hemorrhage. So, if we have a patient who's been receiving magnesium for prolonged amounts of time, that's going to decrease the contractility for uterus following delivery. Okay, especially if she needs to stay on that medication for the next 24 hours after delivery as well. So, we need to be performing appropriate fundal massages. We most likely will need to medicate with more medications following delivery just to be proactive with this patient to ensure that they don't bleed too much. Um, and then what could we potentially see in our newborn? If their mom was on magnesium throughout the entire labor, what could we see?
Lethargic, poor feeding.
poor feeds, lethargic. We could even see some respiratory depression. We could see hypotonia. So these babies can feel the effect of this medication as well, and it can affect them in a very similar way as it has been affecting mom. Okay? Questions on this one? Okay. So before we do case study 3, I need to run to the bathroom. So if you guys want to just take like a quick 5-minute bathroom break, go for it. I'm going to just run real quick and then we'll continue so that we can just end class just a couple minutes early. Okay? Alrighty, everyone. Let's go ahead and do case study number 3. And then we will jump into some Kahoot review. Right. So we have Joni. She's 28 years old. Her first pregnancy ended in a miscarriage at 18 weeks gestation. She is 39 weeks and 2 days of gestation and came into the hospital for spontaneous rupture of membranes the previous evening. Her fetal heart tracing has had moderate variability with accelerations and no decelerations all day, and the patient is now sitting in the rocking chair tolerating her contractions well. What is her GTPAL? So, how many times has this patient been pregnant? Twice. She's been pregnant twice. How many term deliveries has she had? 0.
0.
Yep, 0. G. So she's a G2. Um, T 0. P. So preterm. How many preterm deliveries has she had?
0.
0, correct. Because what gestational age would we consider a preterm delivery?
20.
20 weeks, yep. Um, GTPA. So how many abortions has she had? 1. She had that 18-week miscarriage. And then how many living children does she have?
0.
0, correct. So she's a G2, T0, P0, A1, L0. What is the assessment of the fetal heart tracing? Is it a reactive or non-reactive? Going back to our scenario here.
Non-reactive?
So this one would be reactive, actually. So her fetal heart rate tracing has had moderate variability with accelerations and no decels. So that is a reactive tracing. Okay. Um, let's see what else we have. And what kind of non-pharmacological pain management could we offer this patient? We know she's tolerating her contractions relatively well as of now, but what else could we do for her from a non-pharmacological standpoint?
Reposition her.
Repositioning, yeah, that's something that we could do. What else?
Guided imagery.
Guided imagery,
Breathing techniques.
breathing techniques for sure. Yeah, so repositioning, guided imagery, breathing techniques, hydrotherapy, massage, essential oils, all of those things are non-pharmacological interventions that we as the bedside nurse can offer this patient. So, 2 hours later, her contractions are getting stronger and she requests an epidural. The fetal heart rate continues to be reassuring with moderate variability and accelerations. However, after the epidural is placed, the heart rate changes. The nurse notices that the patient's blood pressure is 76 over 42. So, what's happening to this patient? She's hypotensive. Why? Is it because what's going on?
It's from the epidural.
Yeah, it's from the epidural. So we know that one of the biggest side effects of an epidural is hypotension. Okay, so we see our baby do this. Let's zoom in here and let's interpret this tracing here before we go on. What is our baby's baseline?
D cells?
Well, what is her the baseline fetal heart rate, I should say?
130.
130. Yeah. Is this patient having accelerations? Is the baby accelerating?
No.
No, she's not having accelerations because we know what is our parameter for accelerations? What does it have to be?
Isn't it like a 30 beat increase for 15 seconds?
So close. It's a 15 beat increase for 15 seconds. So 15 by 15. So yeah, you're right on it. So we don't see any accels. Our baseline is 130. Are we having decelerations? Yes, we are. What kind?
Late decels?
Late decels. What causes late decelerations?
Cord compression.
Not quite.
Placenta eruption?
Poor placental perfusion. Okay. In this case, knowing what's going on with mom, what do we think? Why is our tracing looking like this?
So if her blood pressure dropped, she's not perfusing as well. And then that means the baby's receiving less oxygen due to that.
Exactly. Awesome. Yes. So, mom got an epidural. Her blood pressure tanks. She starts feeling like crap, and then all of a sudden, this is what's going on with our baby. Okay? So, mom is hypotensive, so that can be causing poor placental perfusion, poor oxygenation
Right
for
across the
to the
laptop.
baby.
Sit down.
Okay? So, those are all things that we are worried about with this tracing. What are our interventions for late decelerations? What are we going to do as the bedside nurse for this patient?
Reposition.
We can reposition. What else?
Give oxygen.
Administer oxygen to mom. What other things are we thinking? Your mom's blood pressure is in the tubes. What else would we want to do for that?
Fluid bolus?
Fluid. Yeah, we're going to give her fluid. So what's pretty cool, I guess, cool about neo in utero resuscitation of a baby and resuscitation of a mom in a hypotensive crisis is the interventions are effectively the same. Okay. So for our baby, to resuscitate for our baby, we're going to put mom in that left lateral position to increase perfusion to our placenta. So we're changing her position. We are going to administer 10 liters of oxygen via non-rebreather face mask. And we are also going to administer a fluid bolus. If we have Pitocin running, we're going to shut off our Pitocin. For mom, if mom's blood pressure tanks and she's not feeling good, we're doing the exact same things, not only to benefit baby, but also to help out our mom. So we're repositioning her. We're going to lay her on her left side. We're going to elevate her feet. We're going to increase her fluids to bring up her blood pressure, give her some volume expanders. And then we're also going to administer oxygen. Okay. All right. Nursing interventions are implemented, and the fetal tracing is now reassuring with no further decels, and variability is moderate. The Pitocin is restarted, and the contractions are becoming stronger and more frequent. The patient is comfortable with her epidural, and her blood pressure is now within normal range. The fetal tracing begins to show a change in the tracing. Based on the current assessment of the fetal heart tracing, the physician places an intrauterine pressure catheter. Here's our tracing. Gross. We don't like it. Let's figure out what's happening here. So what's our baseline?
120.
120. Yep. Do we have accelerations?
Not
Minimal.
really.
No, we don't. We have these little blips here, but those don't go up high enough and they don't last long enough. Do we have D cells? We do.
Yes.
What kind of decelerations are we having?
Kind of decels more at the peak of the contraction.
Mm-hmm. But like what shape do these D cells look like? Or what shape are they in? Or what do they look like?
V's.
Yeah, so these are variables. You see that abrupt decrease with the abrupt increase? That is what a variable looks like. So what causes a variable?
Cord compression?
Cord compression, yes. What are some things that can cause cord compression?
Positional contractions?
Position of the baby in utero, where it's laying on the umbilical cord. Contractions can cause cord compression. All of that can cause cord compression. Okay. So, what interventions do we do for variables?
Lay the mom on her back and knees to chest.
We could reposition mom. Yeah, move the patient. Put her in hands and knees. Try something different. Why do we think our doctor would want an IUPC?
To make sure that baby's not in distress.
So, what is an IUPC measure?
The intensity of the contractions.
It monitors the intensity of the contractions. Exactly. What else can we do with an IUPC?
Doesn't it monitor the pressure?
So it does monitor the pressure, it monitors the strength of contractions, but it's also a catheter that goes up and is inside of the uterus. So what can we do? What could we potentially administer with an IUPC?
Pitocin?
Not Pitocin. You're on the right track of administering something. Let's think about it. So our baby is somehow putting pressure on this umbilical cord, cutting off oxygen, decreasing oxygenation and perfusion to the fetus. Okay. We know this is positional, but if we know this mom has been, let's say her water has been broke for 6 hours, 8 hours, and she's losing fluid, could a decreased amount of fluid cause that baby to rest more on the umbilical cord? For sure. So what can we do through an IUPC? We can administer an amnio infusion through an IUPC. So we can hook up a bag of saline or a bag of LR to one of the ports that comes from the intrauterine pressure catheter, and we can administer fluid and replace some of the fluid that has been lost throughout labor. Giving more fluid in this situation can bring the baby off of the umbilical cord or move the umbilical cord to a different location and stop these variable decelerations. Okay. So that's why a provider is going to order an IUPC. We don't necessarily, we can see the contractions just fine without an IUPC. These are tracing really well. Okay. If we're administering Pitocin, we might also want to check, like Kristen said, for any fetal distress, because if our Pitocin is causing these contractions to be too strong, that's another issue that we're going to need to solve before baby starts having adverse reaction to that. But an amnio infusion can be administered through an IUPC, which could ultimately potentially bring some pressure off this umbilical cord. Okay. So we're going to anticipate the provider wanting to start certain amounts of fluids, and we're going to get orders for that. So 2 hours later, fetal resuscitation measures are implemented as well as the order from the physician. Our tracing is now reassuring with moderate variability and no decelerations. When the physician placed the IUPC, it was determined that the patient was now dilated to 8 centimeters, 80% effaced, and -1. 2 hours pass, and the physician is preparing to examine the cervix. However, whenever the next contraction begins, the fetal heart rate drops to 70 beats a minute and does not return to baseline. A quick assessment reveals the umbilical cord is now outside of the vagina. This tracing is the worst ever. I would take late decelerations over something like this any day of the week, let me tell you. What is our biggest concern whenever you see this? What are we most concerned about in this moment?
Oxygenation to the fetus.
Fetal oxygenation, yes, excellent. What is our most important intervention to be done? What do we do if there's a cord prolapse?
Don't we position the mom with knees to chest?
Knees to chest. Yep. We're repositioning our mom. What other things do we do as the bedside nurse if we see a cord prolapse? What are our interventions?
Notify the provider and maybe apply oxygen to the mom.
Then notify our provider. Yep. What other things could we do? So someone said we're most concerned about fetal oxygenation. So our most important intervention is increasing oxygenation to our fetus. So we already talked about repositioning mom into knees and chest. What's another way that we're going to get oxygen to our baby?
Apply oxygen to mom.
Give mom oxygen, yeah. But what else? What other probably more important intervention for a cord prolapse would we need to do?
Wouldn't the provider try to lift the head or lift the baby off the cord?
Or the nurse, yeah.
Or the nurse could? Okay.
Exactly. Either one. It does not matter. So typically it's the nurse because what happens is like if I'm in a cord prolapse, that umbilical cord comes out, I'm putting that mom in knees to chest, and then I'm immediately putting on a sterile glove and I'm going up into the vagina and I'm reducing pressure off of that umbilical cord. And you're gonna like physically ride back in the OR bed with your patient. Okay. So yes, this is probably right behind knee to chest as far as interventions go for a cord prolapse. Okay. How is this patient going to deliver? What are we anticipating happening?
A C-section?
A C-section. Yep. We are calling a stat C-section. We are going back to the OR immediately. Comparing this decel to the others that were treated for this patient before, how is this one different than the other ones?
That the cause is not going to be fixed until the baby's delivered.
Yes, this requires immediate delivery of the infant for sure. Um, Specifically looking at the fetal heart rate, what is different about this one than the other decelerations?
It's not returning to baseline, it's just staying below.
Excellent. Yes. This deceleration, this heart rate does not return to baseline. It just stays decreased. It stays down. Okay. So that's what's different than if we look back on this one, because we have a decel, but it goes right back to baseline. Or this one, we have our decels, but it ultimately is going back to baseline. With this one down here, it's not. It drops and it stays down. All right, delivery. The nurse places her hand in the vagina and applies pressure on the baby's head. The cervix is now completely dilated and the head is low in the pelvis. Joni is placed in a knee chest position, and she and the nurse are rolled back to the operating room on Joni's bed emergently. Joni and the nurse are moved to the OR table together, with the nurse hand remaining in the vagina, attempting to hold the baby's head off the cord. Betadine is poured on Joni's abdomen. The scrub tech is exponentially opening supplies, and Joni and the nurse are quickly draped together, with the nurse still on the operating table with her hand in the vagina holding the head. The anesthesiologist quickly administers general anesthesia, and the OB begins the emergent cesarean. The nurse can feel the baby losing muscle tone and feeling a pulse through the umbilical cord as she waits to feel the surgeon's hand hers as he deliver the baby as quickly as possible. The surgeon struggles to remove the baby from the uterus as the baby is now limp and difficult to pull from the pelvis. The baby is delivered and the NICU team immediately begins resuscitation. The newborn is taken. Oh, excuse me. The newborn is taken directly to the warmer to the NICU team. What will the team do first?
We didn't hear that last part.
Oh, I said, what will the team do first?
Apply oxygen?
So
Compression?
before any of that, what is our first step in resuscitating a baby?
Drying them?
Yeah, we're going to dry and stimulate them. Yep. So NICU team is going to get them in the warmer. They're going to dry and stimulate the baby. Once that baby hits 1 minute and we're collecting our APGAR, the baby is limp, has a pulse of 70, is not moving, is blue, and has no respiratory effort. What is the APGAR score? Let's go through it. What is the appearance? What is the color?
Blue.
Yeah, this baby is blue, so that would be a 0, right? Pulse, what's the pulse rate?
Less than 100.
Less than 100, so that would be 1, because it's not 0, it's not nothing. Grimace, is this baby having any type of like response to stimulation?
No, so that's 0.
0. Um, Appearance, pulse, grimace, activity. Is this baby, like we said, is not having any activity. They're not moving, they're not doing anything really, so that's a 0. Respiratory rate. Is there any respiratory effort? No. So what's our APGAR score?
1.
1. It's 1 at 1 minute of life. So when would we get another APGAR?
At 5 minutes?
So we're gonna do it at 5 minutes again. But we're gonna be now doing a lot more resuscitative effort, right? So what should we consider doing for this infant? With knowing this APGAR score, seeing how they're presenting, what should we begin doing?
Trying to stimulate the baby.
We're gonna now start oxygenating this baby. So how would we do that? What is our go-to method of resuscitative, like for oxygen for a newborn?
Isn't that like a CPAP?
CPAP, yeah. So we're either going to do positive pressure ventilation, so PPV, or CPAP, continuous positive airway pressure. That pressure is what we need to expand those lungs for the baby, and also it's going to help elevate the heart rate. Okay, so we need to administer oxygen. For this infant as well, what are we going to do? Besides oxygenating this baby, what else is important anytime we're coding a patient or anytime we're doing any type of resuscitation?
Compressions?
We don't have to do compressions yet because the heart rate is above 60. Okay. If it was under 60, then we would probably start doing compressions. We need to monitor this baby. So we need to put them on a heart rate monitor. We need to put them on a pulse ox monitor. Um, we might need to start an IV and administer fluid or medication. So we might need to administer epi, um, or give a fluid bolus. Okay. This baby too, what are they at a high risk for because of resuscitation and because of this delivery in general? Oof.
Brain damage due to lack of oxygen?
Yeah, neurological deficits. If this baby is being resuscitated, they also are going to be at an increased risk for hypoglycemia. Okay. And hyperbilirubinemia. They're already in respiratory distress. They're in an acidotic state. So they're not also going to have good thermoregulation. So all the things that we always talk about with neonates, with babies. Okay. So let's see here what happens. All right, our resuscitation is successful. Baby is stabilized and taken to the NICU for eval. By the next evening, the baby is out of the NICU at the patient's bedside, breastfeeding and meeting all newborn expectations. The cord gases show the baby had mixed respiratory and metabolic acidosis at delivery, but quickly stabilized. Whether or not the baby was affected from his lack of oxygen will not be determined until he is older, as he reaches anticipated milestones. All right. Questions on that one? All right, you guys are doing great. We only have a little bit of class time left. So let me stop my share here. We are going to play some HESI Kahoot reviews here. So let me pull them up for us. All right, not everybody is going to be able to join because I think there's a limit. Wait, 1, 2, 3, 4, 5, 6. But we can also follow along too with the questions. So if you guys want to go ahead and get signed in, once we have a good number of people, we'll get this one going. And then we're just going to be playing the games until 8. Great. We'll just have a couple more people join and then we'll get going. All right. Anyone else want to come in before we get going? All right, let's start this one up. All right, so why would we get a dipstick rather than a straight calf? What do we think is going on with this mom?
It might have a UTI.
Yeah, she might have a UTI, so why would we not want to do a straight calf?
To introduce more bacteria into the bladder.
Yeah, we do not want to risk put her at risk for developing even a worse or more severe infection. So we're gonna get a dipstick urine, which we can still send off to lab to be tested for any type of bacteria that could be growing. Okay. Yeah, positive ultrasound. So the only positive signs of pregnancy are if we visually see or auscultate a fetal heart rate. Okay. Any other sign of pregnancy can be like presumptive or probable, but the only way that it's positive is if we visualize or hear a fetal heart rate. Okay. Yeah, the level of the umbilicus. Yep, diet. So we are not going to put a patient on insulin unless their gestational diabetes is like extremely uncontrolled, or they already are predisposed for type 2 or are already dealing with type 1 diabetes. Other than that, we're going to be managing it mostly with diet. Yep, we need to be monitoring our patient, our baby, and using the electronic fetal monitoring continuously if we're going to be giving Pitocin. Awesome. Yeah, normal amniotic fluid is going to look clear, almost colorless, and have maybe some little white specks. Awesome. Skin color that is slightly jaundiced, because we know cyanosis of the hands and feet at 12 hours old can still be normal, right? The white papules on the nose or chin are milia, and then those red patches on cheeks and trunk could either be a stork bite or your nevus plexus. Yeah, we're going to notify our healthcare provider. What do we think is going on with this patient?
Iron deficiency.
Yeah, she's anemic. So we're going to need to call the doctor and get some orders. Yep, we're going to get vitamin K. So this would be non-reactive. What is our normal parameters for an acceleration? It's 15 beats by 15 beats. So if at 37 weeks the physician documents that there's accelerations lasting less than 15 seconds, that would be non-reactive because they're not lasting long enough. Okay. A little tricky there. Yep, we're gonna have her perform ankle flexion extension because we don't want her to develop any blood clots. So we need her to continually move whenever she's flying. We're going to assess the baby's position to make sure that they're on correctly and not causing mom to be sore with a poor latch. So we would be worried about low back pain with pelvic cramping because that could indicate that the mom is having a miscarriage following an amniocentesis because we know that that is one of the biggest risk factors associated with that procedure. Yes, we're going to need to talk to our provider about our mom's blood pressure. Okay. Um, so if the blood pressure is low, then that might indicate that she's losing blood very quickly. And then we also want to tell him if it's high because if he wants to administer methergin, he needs to know or they need to know what the blood pressure is and if she's a candidate for that medication. Excellent. Yep, we're going to be giving this patient magnesium.
I got it.
We're going to initiate feeding on the unaffected breast first. With a patient with mastitis, it's important that she continues to feed on that affected side, but we can have her feet on the unaffected side first. To diagnose a hydrocele, we need to use transillumination. And if it like glows red with the transillumination, we know that this is a hydrocele and we can diagnose it. Yeah, so if a baby is tremulous, tachycardic, and hypertonic, we are worried about withdrawal. So we need to obtain a drug screen. Okay. Yes, great job. Low body temperature is a potential indicator of sepsis in young infants. That's what we should be educating and telling our parent. Heat loss. Excellent. Yep. We want to prevent this baby from getting too cold. We're going to turn the newborn to the side and bulb section the mouth and nose. So we want to make sure that we clear out all of those secretions to prevent aspiration. So that's why we would want to use the bulb section. Assisting her to maintain control. Yep. Yep, we need eye shield patches and artificial light. Yes, patients should not get pregnant for at least 1 month following the rubella vaccine. So what do we suspect is happening with this patient? She has abdominal tenderness and bright red bleeding. What are we
Placenta eruption.
Yes, we think she's having an abruption. So we need to replace fluid. We need to give her some more fluid because she's losing a lot of blood. So we're going to be giving her LR as a bolus. Yes, we're going to be getting an accurate fetal growth and gestational age. All right, so let me X out of this one. I'm going to pull up our second one. And we'll go for as long as we can. We only have about 15 minutes of class left, so we'll just answer questions until 8. All right, let's go ahead and get this one started.
Oh, come.
Yes, so if the patient's urinary output stops, we need to stop our magnesium infusion because that is a sign and symptom of magnesium toxicity. So if a baby is that little, like at 12 weeks, we're not going to be able to listen using anything really besides a Doppler placed at midline. So that would be the answer. That's why it's that one. Yes, so what would be concerning would be if we see a bright red discharge 5 days after delivery in our patient. So that is what we're going to need to notify our doctor on. For your guys' HESI, you definitely need to know like the different kinds of lochia, when they should be present, when they shouldn't be present, and signs and symptoms that we would want to report. So our delivered client has a temp of 104. The uterus is tender, unusually large and not descending. So we need to assess our lochia. We need to see what does this patient's bleeding look like. Great job. We need to put the patient in the chest position. Yes, anything higher than 500 mLs would be concerning and would mark our postpartum hemorrhage. Yep, so we need to monitor for a fractured clavicle, especially in an infant who has an asymmetrical Moro reflex. Excellent. Yep, anytime there's mech fluid, we need to watch a baby for respiratory distress. Yeah, what do we think is happening with this patient?
Placenta previa.
Yeah, so anytime there's a placenta previa, we do not want to perform a vaginal exam. Great job. Yep. The only thing that is going to definitely give us a more accurate determination of fetal position would be visualizing the infant via ultrasound. Yes, this patient we're going to reposition. We are definitely going to want to probably let our healthcare provider know these things and assess vital signs, but first we need to reposition the patient. Awesome. Yeah, this would just be caput and it's going to absorb and cause no problems. Yes, we're worried here about potentially a cervical laceration because we feel a firm uterus, but we're still having some bleeding. So we're worried about a laceration that has not been repaired. Yeah, so if we have or we see meconium fluid, we want to make sure that that baby is still doing okay. So we're going to assess fetal heart rate. We want to make sure that baby is on the monitor. These are all signs and symptoms of hypoglycemia, so we need to get a blood sugar on our baby if they're jittery, tachypneic, and hypotonic. Yes, with our oxytocin, we need to see what our contraction pattern is before we increase it because we don't want to be giving our patient too many contractions. Yeah, those are elevated respiratory rates. So guys, for the HESI, you definitely will need to know like your normal range. Your blood sugar, if it's over 40, that is okay. Um, for a faint heart murmur, that can be normal. With the blood pressure for an infant after a C-section, our biggest thing here would be the respiratory rate being elevated because we're worried about respiratory distress. Yeah, this is a G4. So she's currently pregnant. She's currently 36 weeks. She had a term infant, a term delivery. So that's her second pregnancy. A preterm infant at 32 weeks. That's her third pregnancy. And a miscarriage. That's her fourth pregnancy. All right, let's do one more and then we will call it a night. You sound pretty uncomfortable with these feelings that you are having. So we're not going to be like giving them solutions or anything. We just want them to keep talking to us about these things. Have a little open-endedness right there. All right, let me stop my share. All right, guys. So that is about the time. It's about time to be done in class. So, if anybody wants to do extra review or anything, just send me an email this weekend. I could potentially have some time to meet with people if they need to. Next week we will not be meeting because you guys will be taking your HESI. Let me know ASAP if you're having issue registering for your test. Okay. And then just pay attention to the announcements. I will be releasing when we're going to meet in week 12, sometime towards the end of this week, okay? But if anybody has any questions, feel free to stay after. If not, I will see you guys in 2 weeks, okay? Good luck on your exam. You guys got this.
Thank you.
Thank you.
Mm-hmm.
Thank
Is this gonna be
you.